I believe it's now exactly 3 o'clock, and that clock up there is 2 minutes slow. So I propose that we start. I would like first to ask people to introduce themselves because we have some new people with us today. And those who are joining us remotely, please introduce yourselves if you wish to speak so we know who you are. And please speak as clearly as you possibly can because I'm hard of hearing. And when you speak remotely into the chamber, it's not on the loop and it's quite frustrating. If I cannot hear you, I will ask John Topham to praise you what you have, what you've said. Thank you. So can I start here on the left? Thank you.
Well, good afternoon. My name's Gillian Heasom. I'm a councillor for Newcastle Borough Council and the Cabinet Portfolio Holder for Community Safety and Wellbeing.
Sorry, excuse me. John Topham. I'm supporting the Health and Wellbeing Board, working at the Health and Care Department of the County Council.
Good afternoon. Simon Whitehouse, ICS Director for Staffordshire and Stoke-on-Trent.
Afternoon, Chair. Superintendent Carl Ratcliffe, Head of Partnerships for Staffordshire Police and representing Jenny Mattinson.
Good afternoon, Richard Harling, Director of Health and Care for the County Council.
Good afternoon, everybody. Helen Riley, Deputy Chief Executive of the County Council and Director for Families and Communities.
Good afternoon, I'm Tim Clegg. I'm Chief Executive of Stafford Borough Council and Cannock Chase District Council, and I'm here representing the District and Borough Council Chief Executives.
Good afternoon, I'm Simon Fogel. I'm the Health Watch Staffordshire Chief Exec.
Thank you all. Do we have any apologies? John.
Have apologies, Chairman. Have apologies from Gary Jones from Support Staffordshire, Phil Pusey from Staffordshire Skivvies, Gary Free from Cannock Chase CCG, and Roger Lees and Rita Hesseltine from South Staffordshire District Council. I understand Mark Sutton will be attending. He's just going to be a little bit late.
Okay, thank you very much. Thank you. Any declarations of interest? Thank you. Minutes of the previous meeting. Do I have any views on accuracy? Anything within the minutes that you want to clarify or have raised? I just want to make clear that the public health plan will come to us in December and it's preceded by the JSNA in September. Is that correct? The other thing as well is when the obesity is in the forward plan for September, as we know, I would like, I know that 2 dietitians have been appointed to run with this, I think from the Midlands Partnership Foundation Trust. And along with Together Active, I think it is, I would like a dietitian to attend to present as well. And John Henderson is the lead executive officer for this. And given the importance of it, I would like him to be there too for that in September, if that can be arranged, John. Thank you. Any other point about the minutes? Okay. Richard, update. Oh, sorry, is there anybody on here that wants to speak about from outside that wants to speak about the minutes? No, that's fine. We'll then go on to a Kovid update. Richard Harling.
Thank you, Chair. So the good news, first of all, that is that the number of cases in Staffordshire is down by about 80% since we last met at the beginning of March. And our case rate remains quite substantially below the national and regional averages. We continue to make excellent progress with the vaccination programme. Almost 95% of those adults who are most vulnerable, that's people aged 50 and above, have taken advantage of a first dose, and close to 80% have now had a second dose. The NHS is now proceeding to vaccinate people from age 30 and above, and the response from the public continues to be excellent. On the not quite so good news, we are now seeing the emergence of what's called the Delta variant in Staffordshire. This is the new variant that originated in India and which appears to be more transmissible than the Kent variant that was circulating previously. At the moment, the cases seem to be predominantly among younger people, and we are not seeing very many serious cases. The number of people in hospital remains very low. However, it does remain a risk, and we do have a significant outbreak in leak at the moment, which we are working hard to control. So over the next few weeks and months, I think we are in a race between the vaccination programme and the virus. We can speed up the vaccination programme by making sure that people take advantage as quickly as possible, and we can slow down the virus by continuing to take precautions. Remember the hands, face, space, fresh air messages. The more we can limit the spread, the greater the chance that we can keep on top of it and prevent a third wave throughout the summer months. Thank you.
Thank you, Richard. Do we have any questions on that? So broadly, it's talking about good news, but as Boris Johnson said in his most recent update, the race between the virus and the vaccine has narrowed. So we've just got to get on with vaccinating as many people as we possibly can as quickly as possible. Great. Thus, the move from 12 weeks to 8. Good. Thank you.
Thank you, Johnny. I'll introduce this, and Wendy, who is on the Teams, will also do a slot on the JSNO in a sec. I'll just quickly introduce it, though. The paper which came around in the pack was really to start to gather some momentum for well, what is essentially the board's strategic duties, I suppose, and the board's legislative duties. Just to remind board members, the Health and Wellbeing Board is required to produce a joint strategic needs assessment, and it is required to produce a joint strategic Health and Wellbeing Board strategy for Staffordshire. Those are in legislature and are what every Health and Wellbeing Board has to do. And those documents are really intended to provide a context for other partner organisations, NHS as well as local government and beyond, to build their plans moving forward. So that's the context of that. So this is really cutting to the core of what the Health and Wellbeing Board is here to do. So what the proposal is in the paper is threefold, I suppose. The first one is, and I'll come on to this in a second, but I'll cover them all off first before I come back to Wendy. The first one is, that kind of precedes all of that, is produce a joint strategic needs assessment. For the board members that were present a year or so ago, we did do a joint strategic needs assessment pre-Covid, actually, which was probably about 18 months ago. It could have been a little bit less, actually. We did that just pre-Covid, but obviously with the pandemic and everything that's gone with that, the environment has changed a little bit, and we're bringing forward a proposal to do some more work on the joint strategic needs assessment, which I'll pass over to Wendy in a second on. Linked to that is a kind of a shift towards thinking about Health and Wellbeing Board strategy as well. Now, for those board members that remember, the last strategy was put in place in 2018 and was relatively short and had a focus on healthy life expectancy, actually. But obviously, things have changed somewhat in terms of the environment in Staffordshire with Covid, and we were suggesting to the board that it's probably not a bad idea to revisit that and come back following the joint strategic needs assessment to actually revisit the strategy a tad early. The strategy itself was due to finish in 2023, so obviously it will be a year or so, well, a couple of years earlier in that, but we'll seek approval for that towards the end of this slot. that proposal. The final bit of the trinity, I suppose, of proposals here is around the Director of Public Health report. The Director of Public Health report is an annual, well, normally it's an annual. We've had a bit of a hiatus, of course, for the last year, but normally an annual report that is produced by the Director of Public Health, and usually it focuses in on key issues for Staffordshire and with some recommendations. Obviously, with COVID, the Director of Public Health report this time is going to be around COVID and some of the learning from that, and some of the experience around COVID actually, and will complement the Joint Strategic Needs Assessment by probably what I would characterise it as a more qualitative look at some of the experiences and some of the responses that we did during COVID, which will then lead into a Joint Strategic Needs Assessment, which will provide some of the more data-driven, more detailed data around issues in Staffordshire. So the proposal is that we bring a draft of that annual report to the board in September. So that's as far as I want to go with that. We'll come back to those recommendations towards the end, and we can just get approval from the board. But I just want to pass over to Wendy, who wants to do some headlines from the Joint Strategic Needs Assessment and wants to just run us through the proposals for running that prior to bringing it back fully in September. Wendy, over to you.
Thank you, John. Wendy Thompson, Research Manager at Staffordshire County Council. Good afternoon. I'll just share my screen. I've got a few slides. Now, can everybody see that on the screen in the chamber?
Can you put them on full screen, Wendy?
Yeah, just bear with me. That's better. Okay. So thanks for introducing this, John. Just to obviously update, really, we've got a few slides here that talk through the approach we want to take to the JSNA this year. And basically, as part of this as well, we've already started to do some analysis looking at the existing priorities and what may have changed or emerged. So we've also got a few headlines as well to kind of update, I guess, with some of the emerging analysis to date. And what we'd be really keen to do is use that, I guess, to form a discussion today and take any views with a view to finalising the JSNA and bringing that back to the board in September. So as obviously it says in the slide, we are really keen to build on the comprehensive JSNA that was undertaken last year. A real focused, I guess, approach last year in terms of trying to kind of look through all the data and pull out the kind of key areas of focus, but building on that further this time, recognising obviously COVID will have had an impact on our health outcomes, and also wanting to take, I guess, a bit more of a focus on our local assets as well in terms of building on the strengths, because we know a lot has happened, and I guess there's a danger, isn't it, that the JSNA can sometimes be very focused on the data and some of the kind of negatives, but actually reflecting an awful lot of work has been done over the last year or so to kind of address some of those needs. So really keen to reflect that as part of a needs and assets-based assessment moving forward. Something to kind of note, which it says really in the last bullet point, obviously a lot of the published data that we have access to is still pre-COVID. So I sort of caveat that across all the kind of data that we're presenting, really, that a lot of this doesn't reflect COVID impact yet. So where possible, we are obviously going to look at national policy, qualitative data that we've managed to get through consultation and engagement, and also any other local data that we might happen to have, and equally work with our partners as well, who will be holding data that will give us a bit more of a kind of up-to-date view of the system. So we're proposing really that the JSNA kind of takes three core components. I guess the first bit is pretty much what John said. Let's have a look at what the data's telling us, what are the key issues coming out, where have we seen any change or shift, and then start to explore some hotspot analysis where we might be seeing multiple poor health outcomes in certain geographical areas. and included within that start to bring in some of the kind of assets work as well, if the board is supportive of that approach. The second element, as I say, because the data doesn't really give us that very up-to-date view, is to do a COVID thematic piece. So looking at what data or national policy and evidence that we can get to understand the impacts on health outcomes. Supplemented towards the end of the year, we are proposing, and this was something that we wanted to do last year, but COVID hit and obviously things took over, is to look at, obviously, as the board finalise its joint health and wellbeing strategy, is some interactive dashboards that would then help support the board in monitoring its priorities. So that timely intelligence and data that enables, I guess, to target action in a timely way. So we'd be really keen to kind of work with the board on that as it finalises its health and wellbeing strategy post-September. And just a point to say, obviously, there is a children's JSNA as well, which we produce in conjunction with the Family Strategic Partnership Board. So they are designed to complement, and some of the priorities will clearly overlap, but very much a consistent complementary message across the two where relevant. Just a quick recap then. These were the 6 issues that we mentioned in the last JSNA last year. We've, as I say, undertaken some recent analysis just to get a view of where Staffordshire might be a particular outlier, where we might be seeing any change or shift in the data from the previous reporting period. Where possible, in the headlines, we've just incorporated some elements of impact as a result of the pandemic. And I will obviously run through those. Just as I know, Johnny, you alluded that obesity is obviously going to be a key area of focus. I understand obesity and mental health has been identified as a focus by the board. And I think when we get to this, the data very much confirms that they are still priorities moving forward. So just one slide for each of the kind of key priorities, just to give a bit of a view as to where we are at. So as we know, focusing on some of the positives, really strong early years performance, 3/4 of our children are school ready, and Staffordshire is one of the top performing of its authorities. It is Key Stage 4 education that remains the kind of key concern. Again, same message as last year, 2/3 of our young people aren't achieving a core level of attainment at the time that they leave school. Unfortunately, we don't have any latest data for obvious reasons with the pandemic. Attainment data hasn't been collected in a way that is comparable with previous years. So we are very much still working on the revised data that was published in 2019. Positively, 80% of residents are in employment. That was as at 1920 data, so pre-COVID, but has very been much a positive story for the last few years, rising to 80% from 74% 5 years ago. And we are one of the lowest in terms of unemployment rates among our statistical neighbours. Whilst that data is somewhat old, we do have our claimant count data, which gives us, I guess, a more up-to-date view of COVID impact. Whilst COVID has had an impact, and like elsewhere in the country, we have seen a rise in our claimant numbers. The Staffordshire rate remains well below national and regional rates. So Staffordshire's rate is 4.7 compared to national of 6.5. What the data does tell us is that we are seeing a disproportionate impact amongst our young people, though, who are kind of at the greatest impact of unemployment, and are also very much in those hospitality sectors that have been impacted as a result of lockdowns. And I guess just to reiterate that as well, from our COVID resident survey that we undertook last year towards the end of the first lockdown, that almost also confirmed that it was young people that were more worried about their financial situation and their job situation at the start of the outbreak. And just one final thing to pull out, I guess, in terms of what shifted from last time, fuel poverty continues to fall for the second consecutive year to 10.1%. It's fallen from 12%, which was reported in 2016. But that shift has now meant that we are statistically lower than our national as opposed to higher than national. And we will obviously continue to explore using other data available to us, kind of social and other economic impacts that we can build into this. Aging well, I guess the key one up front is excess winter deaths. This was something that we previously reported as being one of the highest amongst our statistical neighbours and higher than national. But we have seen a real positive shift in the latest reporting period. So we have come down from 39.9% to 14.2%. From being higher, we are now similar to national and average among our peers rather than being one of the highest. I think one of the key things to pull out is healthy life expectancy, as we know, is falling for both men and women. So men, it's fallen by 1.8 years and women 1.1 years. And it is male healthy life expectancy that is the third worst amongst our similar authorities. Covid will obviously have no doubt an impact on this further if you look at the national evidence, and therefore it is likely that there'll be more time potentially spent in ill health as a result of Covid, coupled with a growing elderly population that we will see in the next 10 years, again, has a further potential to impact on healthy life expectancy. Also wanted to, I guess, reiterate around the Covid survey where we do have more later data. It was interesting that people that had reported the most negative impact as a result of the pandemic were those people A, furloughed, or B, had a disability or limiting illness. So 67% of respondents with a disability or limiting illness said they had a greater negative impact on their life. Particular concerns around access to healthcare and longer term impacts on their condition. Moving on, so mental well-being, as mentioned, I know this is an area potentially of focus for the board, and the data certainly reflects that this is a key priority, particularly in light of COVID. A lot of the national evidence is telling us that social isolation, loneliness, the uncertainty is contributing to a worsening of mental health, and is also a widening of pre-existing inequalities in mental health, particularly among young people and women. And that was also reiterated in our COVID survey that we did last year as well, where it was quite stark that more younger people were worried about their mental well-being than older people. So 61% of under 35s were worried about their well-being compared to just 25% of people who were 65 plus. Looking at some of the data, which is pre-COVID, obviously we are seeing impact on the system. So we have, although we've seen a small reduction in admissions for intentional self-harm, we are still the fifth highest among our similar authorities. GP recorded depression continues to increase, and that trend it has been the same for the last few years and means we still remain higher than national. Something that's come out through the data this time is an increased rate in suicides. So for the period 2017 to 19, which is the latest period we have available, the increased rate in suicides has risen to 11.5 from 10.3 per 100,000. I shall just move on. So healthy lifestyles, again, I know excess weight and obesity, again, a key issue for the board, and the data certainly suggests that this is an area of focus, particularly among reception age children and adults. So 1 in 4 children have excess weight and 2 in 3 adults with excess weight issues. Whilst the levels remain the same as the previous year, Staffordshire still remains higher than national and compares less favourably to its peers. Positively, there has been some improvement at year 6. So for excess weight, we have seen a decrease to 33% and now much lower than national as well. Looking at physical activity, 2/3 of our adults are physically active, which is really positive. But we are just seeing a small increase in inactivity among adults from 21% to 23%. And again, you can see some of that impact on the wider system. So higher prevalence of obesity-related conditions, particularly when you look at obesity-related emissions, which is higher than national and is a continuing upward trend since 2014. Alcohol and drugs. As mentioned last time in the JSNA, and a similar picture with the latest reporting period, it is more alcohol that's the issues than drugs. We are seeing alcohol-related emissions continue to rise in the latest data. And interestingly, that's in contrast to a trend that is reducing nationally. And Staffordshire still has one of the highest rates of its statistical neighbours. Looking positively, there are more people successfully completing treatment, which is risen to 42% in 2019, previously 34%. And we, although we are still higher than national, we are higher than national, which is obviously a positive, previously in line with national. In terms of COVID impact, again, just looking at what local data we have available, the COVID impact survey reflects what we've seen in the narrative nationally. Respondents did suggest that they were consuming more alcohol, particularly during the first lockdown. So 31% of people reported that they consumed more alcohol and 10% consumed less. Interestingly, the impacts on the system are yet to be seen. So some of the metrics around liver disease and preventable mortality remain stable. So I guess we're not quite seeing that impact on the system as yet. And finally, maternal and infant health. So a slightly improved picture. So for the last 2 reporting periods, we've shown a reduction in infant mortality rates. We were previously higher. We are now almost close to the national average and have reduced over the kind of, as I say, the 2-year period. Despite this improvement, though, Staffordshire does still remain one of the highest with infant mortality rates among its neighbours. When looking at some of those contributing factors, which we looked at last time, it is still the same picture that we very much remain in line with national for the majority of areas, but it is smoking in pregnancy and new birth visits within the first 14 days where we are below national. So smoking in pregnancy 11.8% and new birth visits down to 73.6% from 82.5%, and also the third lowest of our peers. So that's a bit of a kind of quick run through the headlines. Obviously, what we are keen to do is have that conversation today to try and overlay some additional intelligence with this. And obviously, we want to very much kind of then get beyond the headlines now to look at some geographical analysis, looking at some of the hotspots, what other data we can bring into this to kind of give a more up-to-date picture. But hopefully that just gives you a feel for some of the headlines and what's changed over the last reporting period. As mentioned, I'm going to hand over to John. We are very keen this time, as we say, to look at a more asset-based approach. So we are wanting to look at the needs alongside the assets. So we're doing an awful lot to contribute and address these needs. And I will hand over to John.
Yeah, sorry, excuse me. I don't want to dwell too much on these, but they're really in there because I think we wanted to characterise the JSNA as not just a joint strategic needs assessment, but actually as a joint strategic needs and assets assessment. Because I think a more strengths-based way of looking at things is probably the way lots of us are going, but actually it makes sense. We know that identifying some of the deficits gives us somewhere to focus, but actually the assets that exist in our communities that we've learned through the COVID period are really quite valuable and quite important for helping us overcome some of those issues as well. So the slide there is really just to reflect that. And that slide comes out of the first lockdown, some of the stats that came out of the first lockdown, and characterises some of the massive effort that was undertaken in our communities. Do you want to just flick on to the next one, Wendy? Yeah. And that second slide just covers some of the things that we're delivering within our supportive communities delivery programme, and it's that's a part of a bigger picture. And the assets assessment we would hope would go a little bit further and cover some of the other assets that other organisations are aware of. We know we don't know all the assets and haven't tapped into all those assets, but we also know there's a lot of stuff out there. So that's what those two slides were really there to try and characterise, the fact that we wanted to also put a big emphasis on the assets part of this as well. And I think that actually is quite a difference and quite a change and step change for the Joint Strategic Needs Assessment. Okay. Once again, a further characterisation of the assets. Staffordshire Connects is our signposting tool at the County Council. It's a digital signposting tool, so not for everyone, but that just shows the type of traffic that comes into Staffordshire Connects. 26,000 website hits in 1 month alone, with a range of hits on different issues around adults and communities, health and wellbeing, carers, etc., and money matters in there too. So people come to the County Council signposting services for a whole host of bits of information, and that gives us a kind of a feel for the kind of issues that are on people's minds out there as well. I think that was the last slide. No, it wasn't. That was the next steps.
Almost the last slide, yeah. So we've just got obviously some kind of key next steps. So certainly from today, obviously any feedback very much welcome. We are really keen to understand the board's views around taking that more asset-based approach, and also any potential gaps from having heard, you know, through those headlines today. Is there anything that we're missing? Anything we need to go away and have another look at? As ever, the data tells part of the story, but is always useful to overlay with that intelligence as well. Obviously, we will then take that and work towards finalising the JSNA for August, ready for the September board meeting, where we will present the final JSNA. And much like last year, take any feedback and then look to publish that by the end of September. And then continue to work with the board around its joint health and wellbeing strategy and what we can do in terms of developing some dashboards to help monitor the priorities and support, I guess, targeting of action as part of that.
Wendy,
Thank you.
Thank you. Thank you, Wendy, and thank you, John. That's really helpful. Can I take questions from those who have dialed in to begin with? If you want to speak and you've dialed in, then put your camera on and wave your hand at me. I have none. Okay, I'll now take questions from the floor. Thank you. Tim.
Thank you, Chair. First of all, to say that very much support the approach, both in terms of looking at the outcomes of COVID and taking an asset-based approach. I think that's a really positive thing to do. I would be interested in gaining more information, perhaps over time, if not today, about how you intend to gather the evidence, because I think clearly not all of the outcomes by any manner of means from COVID will be able to be quantified at this time, and therefore that qualitative as well as quantitative evidence is going to be really important, and also over time how it translates into service demand, both for health service colleagues, local government, and our community and voluntary sectors. I suspect that quite a number of organisations, including my own, have done a number of reviews of the impact of COVID on our services and indeed the community response to those, which can feed into this. And I think some clarity from public health colleagues about particular areas you might want to look at so that we can help you with pulling out that information would be welcome. We can quite happily provide you with a very long report, but in terms of you being able to get the value from that, then some idea of areas that are coming out that you're particularly interested in, I think would be helpful. I guess part of this will be a comparison with where we were with the key issues that have been identified from the previous JSNA and which were referred to in the presentation will be quite important, particularly the impact of COVID on things like the social determinants of health and the health inequalities would be really well worth looking at, and some reference to how people feel able to access services in their widest sense, I think would be of great value. Two final things. I think the asset-based approach is really good. I think to achieve the best out of that, we probably want to take a longer-term view of the impact of COVID, and this might become a recurring theme over a longer period for us to pick up, because I suspect the full impact of it won't be known for some time. Thank you, Chair.
I think part of the answer to your question, if I may, before I resort to Wendy and John, is that it's going to be a live iterative document. So, for instance, as we get qualitative stuff further down the line, we can feed that into the document, and it's there for us to keep looking at. Who's going to field the questions? John.
Sorry, say again, Johnny.
Who's going to field the question? Because Tim did ask a couple of questions.
The ones I got down, so I might have missed some of these, was how we're going to do the how we're going to assess the assets, I suppose, if that's the right way of phrasing it, and do the qualitative stuff. I think there's a question mark about how we make that work. There was one around, I think it was around the geographical spread, because there was something about focusing in on inequalities and kind of like where those inequalities are, because that's a helpful way to think about how we approach the assets. There was something around comparisons with the previous JSNA as well, around the dashboard. And I think the final one that I picked up linked to the other one, which is around assets. Good idea, but we need to think about this in the longer term as well, and this is about how we grow it. Is that fair reflection, Tim? Yeah.
So, I mean, I obviously can respond on some of those points if that's helpful. So, I do agree, as you've alluded to, some of these, we won't see the data certainly showing any impact on health outcomes for potentially years to come. So I think it is going to be an iterative process. It's very much going to be about looking at not just the quantitative data, but also doing qualitative research as well, so we can kind of really understand those views. And I do appreciate that there is an awful lot going on in terms of in that field. So again, as you mentioned, Tim, obviously if districts and other partners are sitting on information that enables us, I guess, to enrich this picture, then that would be very much welcome and would neatly feed into the kind of COVID analysis that we're doing. Much like we started to do, is hopefully today's kind of shown, is we've started to look at those kind of key issues as that starting point. So yes, looking at then any COVID impacts and any data that partners have, whether that be qualitative or quantitative data around demand or experience and perceptions, then obviously we very much welcome feeding that in, and that would, I think, neatly feed into what we're proposing as our approach. And it is going to be one that we're going to have to kind of monitor and keep up to date as we obviously go through the kind of coming years. And hopefully as well, if we establish a focused set of dashboards on the kind of key issues that the board wants to monitor, then also, that will provide some of the kind of timely data and intelligence to, I guess, focus its work and priorities. But as I say, I do think it's going to be one of those iterative pieces. And yes, partners have data that they can feed in. We would very much welcome that. It is a joint strategic needs assessment. So all and any data welcome for us to build that picture.
Mark.
Thank you, Mr. Chairman. My apologies for being a little bit late as well. The traffic between this morning and this afternoon is obviously as a result of something on the M6 that wasn't there this morning. The first slide when we were talking about the JSNA was about the wider determinants. And the first point on that was early years, and we saw the fact that 3/4 of children reception age get a good level of development. That clearly still means that 1/4 of our whole population at that age are not in effect school ready, and it'd be interesting to know how the effects of COVID will impact on that. So that, I think, without COVID, is already an area that we need to and should concentrate on, because I think long term that can improve the whole determinant of a lot of things, but particularly health, over many, many years. And it's not a short-term thing, it's a long-term thing. So it's a plea really for that to be a priority in what we do going forward.
Thank you. I didn't see a question there, so we'll take that as read. Thank you, sir.
Thanks, Chair. Just a couple of points, if I may. First of all, supportive around the asset opportunities. I think we've all seen how communities in particular have been mobilised during the pandemic, so we'd certainly be supportive around that. The second point, I suppose, is an offer around the qualitative information, certainly around vulnerabilities and in particular suicide and the increases that we've seen, if we can assist in that way in particular. And then the third one, I suppose, is a question stroke observation. Maternal and infant health. Is that a bit old-fashioned now? Should it be parental and infant health, not just focusing on mum? We have same-sex relationships, surrogacy, so fathers are just as important in those circumstances as mums are, so perhaps just an observation.
I'll field that as a question. I think you're right, and we'll change it. Thank you.
Thank you.
Okay. In closing this, I'd just like to say a couple of things. I think this is hugely important, this JSNA. I think we need to use JSNAs more than we've traditionally done in the past in terms of making them work for us. And I take Mark's point about the 3/4 of the children are school ready, when effectively a quarter aren't. And I think the way that we frame this document, we should make it a bit harder on us than we've done in the past. And emphasise the fact actually a quarter aren't ready. And sometimes we get a bit complacent when we compare ourselves with other parts of the country when we're a bit better than they are, when actually everybody's not very good. So that there's that side of it for me. There's a few bits that from a clinical perspective I think is important coming out of COVID that hasn't been mentioned. I think the risk of the prevalence of agoraphobia may well have increased. People just not having, if not frankly agoraphobic, just not having confidence when they come out of the house, and as a result, both their mental and physical health will deteriorate in the long run. The whole business of loss of function, particularly for the elderly, and the resultant increased risk of falls, I think is going to be very significant. And I think we need to hone in on that. And look again, obviously, at the obesity and mental health piece generally. I think the assets bit is really important, because we want the GSNA not just to tell us what the problems are, but how high the hill is to climb. And without the assets, as Tim mentioned, we won't know that. Thank you, and I look forward to the September document.
Thank you.
Mental health update, prevention and strategy. That's Chris Stanley and Jan Cartman-Frost. Thank you. Chris, welcome.
Thank you. Jan
is Jan
just,
with you?
She is. She's in the same room. She's just working on sharing the document as we speak.
Okay.
If it's not working, do you want me to try and share mine? We're nearly there. There we go. Something's happening. Right. Okay, so yes, it's myself, Chris Stanley. I'm a commissioning manager with Public Health at Staffordshire County Council. So I'll start, and I'll let Jan introduce yourself, because I can't remember your job title at the moment. I'm going to just talk a little bit about the actual sort of the prevention side of it, and an update on what's happening at the moment. So first slide, please, Jan. quite pertinent to that last discussion, I was just going to give you a very, very quick overview of what we understand to be the situation regarding the impact on mental health, and in particular in terms of suicides, over the last 12 to 15 months. As you've seen from the previous presentation, we're already in a situation of increasing rates of intentional self-harm, particularly in young people, GP-recorded depression and suicide rates. But understanding the impact, as you've already referred, in recent years is quite hard to quantify because of the different effects of the pandemic itself, and also on, of course, the lockdown and the provision of and access to services. Initially, obviously, demands on mental health services dropped initially, but that's now reversed, and both adult and young people's mental health services are now seeing very high levels of demand. I can't give you numbers, but I've just been given that as a qualitative statement. There's the Staffordshire Mental Health Helpline that saw quite a large surge in calls, including a lot of suicide-related calls in late 2020. Some of that might be because they actually increased the hours. They became a 24-hour, 24/7 service. But I'm advised again that a lot of those calls were made during normal operating hours. So it does suggest a real increase in number of people calling and expressing their need for help. However, at present, that doesn't necessarily seem to have translated to an increase in suicides over the last 12 to 15 months. Official Ordnance Survey figures have got to be treated very carefully, by the way, because of the inherent delay they're based on the registration of deaths after inquest, and there is a long delay in that. And in fact, the ONS survey data up to September 2020, of that, 60% of those deaths actually happened prior to 2020. So you've got to be very careful with reading anything into that. However, there's been a number of bits of work around using national real-time surveillance studies during 2020 up to sort of winter. At that point, it didn't show any evidence of an increase. Data from our own mental health trusts doesn't show an apparent increase in the last 12 months, and similarly from the Highways Agency, it doesn't. However, that's not the whole picture. We haven't yet got a sort of a feel fully from the police. I know that colleagues in the police have expressed concern that they think there's been an increase in attempts in domestic premises, so there could still be a real issue there. And there's a known phenomenon, of course, that suicide rates increase after a period of crisis rather than during it. So it's definitely something we still need to keep a close eye on. Next slide. So just briefly, and to sort of give you a summary of what we're doing in terms of suicide prevention, we're on the final year of funding from the Wave 2 National Fund for Suicide Prevention. We're using that to provide a self-harm support service. Levels are particularly high in Stoke, but also in Newcastle, much higher than the national average. We're funding a real-time surveillance officer based with the police, so hopefully we'll get some of that data I just talked about soon. We've been running a lot of suicide prevention training, which has been really successful. We've run nearly 700 courses so far. Well, 35 courses, but nearly 700 people have been to those. Really good response from those people who've gone to them, and we're going to continue to offer that another 600 during the next, from June this year to from this month to next year. And there's also quite a bit of mental health first aid training, post-prevention bereavement training for ambulance services for GPs that we're also putting on. And we're also developing a program of targeted community engagement with trying to identify suicide prevention champions who will be engaging with businesses associated with opening up, and a program we're working with sports clubs. Next slide, please. Just a quick run through of some of the campaigns that we're running at the moment. We've got the Talk Suicide campaign, which was launched last year. That's been really successful in driving people towards the zero suicide. I've forgotten what it's called. What's it called? The Zero Suicide Alliance training, which is an online piece of training. Over 1,000 people have gone to that. It's been the main source of driving people to the half-day suicide prevention awareness training that I was talking about earlier. And it's been picked up by a number of other partners. Burton Albion were interested in it, did something with it. Stoke actually did a kind of Stoke Football Club did quite a lot with it. But particularly excitingly, Keele and Staffordshire University ran campaigns based on extending the Talk Suicide campaign. And we'll be keeping that going as a brand, if you like, to keep the message going. We've just come to the end of a campaign called Let's Beat Loneliness Together, which was a targeted campaign supported very much by our own corporate communications team. So that's not only about providing advice and encouragement, but there was a localized element directing people to local befriending services and broader services such as that run by Everybody Health. We're going to continue to do some work with parish councils to sort of develop a program of ongoing localized activity around this. And we're soon to launch the new iteration of the Do It to Feel Good campaign. That's going to be a mental well-being campaign based around the 5 ways to well-being. And like the Let's Beat Loneliness Together campaign, that's going to be very much targeted. So as well as sort of key statements around people's about ways to sort of maintain your own mental well-being, it will be using targeted information to go back towards community assets that are actually relevant to those different ways to well-being, and we'll target that appropriately across the county. Thanks. And just very quickly, just a really broad, non-exhaustive overview of other things that are going on. The Supportive Communities programme that Public Health are running broadly is going to be, it has a lot of elements which tie in with the mental health support work. We've included provision of mental health awareness training as part of our Supportive Communities programme and that's mainly aimed at volunteering community sector, libraries, anybody really who comes into contact with people, vulnerable people particularly. The community help points that we have are referring, a lot of those that are coming in are about befriending, so we're referring people to local befriending services and promoting the Entitled to benefits application. We have a Community Champions programme which is under development at the moment. Currently in East Staffordshire, it's mainly been looking at vaccine hesitancy, but there's an interest from the community that we've engaged there with about messaging around support for mental health. So that's probably where we're going to go with that next, and we'll be able to link in with the ongoing mental health transformation programme as part of that. And I've just briefly mentioned other things like digital inclusion PAN. There's other elements that the council's working on which are very much related to social isolation, and what we'll be doing is seeing how we can work that into the local stuff that we're doing, particularly, for example, through that parish work that I mentioned earlier. Other areas of the work may be identified as we begin to work on the public mental health, mental well-being elements of the new mental health strategy. And with that, hopefully segueing nicely to Jan, I'll pass over to you.
Thanks, Chris. So my name's Jan Cartman-Frost, and I'm the Senior Commissioning Manager in the All-Age Disability and Mental Health team in Health and Care. And I've recently joined the team, and one of my priorities is going to be leading on the new mental health strategy work. So very brief bit about the background, which I think the board will be aware of. So the Staffordshire County Council and the CCGs currently have a mental health strategy which covers the period from 2014 onwards, and there's obviously been some discussions and agreement late last year that we would develop a new strategy from 2022 for the next 5 years between the County Council and the CCGs in Staffordshire, and it will be a co-produced joint strategy for mental health. So a bit about the approach that we're going to take to the mental health strategy. So it will have it will be public health and prevention inclusive. So it will set out to achieve a holistic end-to-end strategy for people. So with the focus on helping people to stay well longer and delay being drawn into health and care services too early. Many people won't require statutory acute services, but may have periods of treatable lower level mental ill health. And also that people may move from different parts of the system, the health and care system, throughout their lives. It'll be aiming for a joined up offer, so a whole life approach to improving mental health. So we're not going to rewrite a strategy where there's already existing more recent ones. So children services have got a children and young person's mental health strategy. We've got a suicide prevention strategy, but the aim will be to provide links to those existing strategies so that we create a more whole life approach for people. As people's mental health is the sort of foundations of their mental well-being is developed when they're young, but they often need support and treatment in later life, it will be making those connections. We also recognise that it's a health and wellbeing board priority, mental health, and that this will be reflected, we expect, in the next health and wellbeing strategy, and the mental health strategy will provide some of that detail, that underpinning detail. So a bit more about the approach. So we've already talked quite a bit around asset or strength based. So I've used the term strength based here, but it's similarly, so it's going to be a asset or strength based approach. So making use of individuals and community strengths and assets, again, helping people to stay well longer. So I suppose the things that we want to find out about is, do people, so leading on when I talk about the engagement, so do people know how to stay mentally well, what solutions are available to them locally, and where they can go for help when they experience early problems. We also want to look at considering the importance of place, so what localities, and that's very key to asset and strength based, so what are the localised approaches and what differences are there amongst communities. So we want to make it sort of localised. And then the long range shadow of COVID. So I'm quoting here Professor Chris Whitty. So he spoke at a publicly held conference in March this year on the anniversary of the first lockdown, and he spoke about the long range shadow of COVID. So he described it as a very big job of work, preventing lifelong problems related to effective lockdowns, such as increased deprivation and non-COVID related health issues. For some people, and I think the previous section, Wendy will, obviously the JSNA will really support this. So for some people, there may not have been a great impact, but for many people, the physical and mental well-being will have been very badly affected. So we obviously need to consider the long-term impact of that. So coming on to engagement, so part of the change, which I'll come on to, the change of timescales, was in recognition of the fact that the CCGs are leading on the community mental health transformation, and that included some significant engagement, and that engagement has taken place to support this CMHT. And so we have delayed our engagement around the strategy. This will allow the CMHT engagement to have happened, but also some of the CMHT work to progress, and therefore we can take some of that into account in how we plan our own engagement. So our engagement, so what we want to ensure we do is that it's across the whole health and care system, so acute, community, statutory, commissioners and clinicians, practitioners. So I suppose one of the challenges for me about how do we make sure we engage everyone and no part of the system is missed. So because it's a prevention and public health and place-based, so how do we engage with wider populations and people within communities? So those wider populations, not just patients and service users. So what about people who have mental health problems who only get as far as support from friends and family or employers? The demand on GP services, and also voluntary sector who are providing support to people with mental health problems. And obviously, finally, very importantly, lived experience, including people who are receiving support again from community, acute and statutory health and social care services. So finding out how was it for them. And I think one of the things we do want to look at, we've done some early work around engagement, but we want to re-look at that. Now it is more of a public health and prevention focused or inclusive strategy. So the timelines we're now working to, so we are aiming to do the engagement consultation for the new strategy from September to mid-October, and that will inform a draft strategy in November 2021, with the aim of that going through governing bodies in December 2021, and then the aim is for the new strategy to commence from April 2022, supported with appropriate implementation plans. So I think the aim for me would be a snappy strategy, so something that isn't massively lengthy, that probably won't get a huge amount of people reading through a great deal. So it's got to be appropriate level of detail. But I think the CCG strategic leader myself agree that actually the implementation plan is going to be what is very important. And again, we're thinking about some targeted engagement around the implementation action plan. So whilst the strategy will set out what we should aim to do, we'll be interested in getting feedback from, again, that engagement around how we are best to actually achieve some of those things. And we want, again, the ownership around the strategy it will be key to making sure those action plans are delivered on. So for my final slide, I've posed some questions for the board and perhaps to ask for feedback. So I spoke about, the Chris Whitty presentation around the long range shadow of COVID. So I suppose one of the questions for me is, can we predict where and how we will see this in Staffordshire? So again, the JSNA no doubt will support that, and feedback from board members. So and then how can we use the mental health strategy to make a difference to that? The other challenge I think for me will be is actually the timescales we're working to. How much intel will we get about the long-term impact of COVID in that time? So secondly, how can we build a place and asset-based approach to mental health strategy? So how feasible is that, and who are the key people to work with on localities? So Staffordshire is a large and varied county, and in all the sort of health and care system, who will be the key people for us to work with on that? And I suppose for me around asset base, so how do we encourage people to see finding out how they can support their own health as a strength and what their community to do, rather than, this is perhaps something I've thought about, is rather than it's a save the NHS or a cost-cutting exercise, but more about this is a really sustainable way of life for us all. So how will we get that message across, and how we kind of capture some of that in engagement? And then finally is kind of ask for the board's support to engagement across the whole health and care system. So the longer term ownership of the intentions of the strategy, and ensuring that the actions that are in the action plan is implemented across the whole system, so we achieve a parity with physical health priorities. So that's the end of our presentation, and then we'll take questions. It might be helpful, Chair, if maybe I take questions on the strategy, and then again, Chris, you can come in if there's any further questions on Chris's section.
I'm content with that. Can I first take questions from those who, and thank you both for your reports, they were very comprehensive. Take questions from those who have dialed in, and then I'll take questions from those from the floor. Peter.
Afternoon, everybody. Thank you, Chair. So apologies, I was a little late for today, and that's because...
Peter, there's some new people who are here, so can you just introduce yourself first so people know who you are?
Yes, of course. So Peter Axon, Chief Exec at North Stafford Combined Healthcare NHS Trust. So as I said, apologies for being a little bit late. I was actually chairing the Mental Health Programme Board for Staffordshire from 2 till 4. Unfortunately, I finished a little early, so I was able to get into this session earlier than planned. I suppose listening to the narrative that's just been described, fundamentally, it's the same as the conversation I had a couple of hours ago. And I suppose I'm a little bit worried that as the chair of the Mental Health Programme Board, and that's an agnostic chair, that's not also chair of Combined Healthcare, that's not being a commissioner, that's not being a provider, that is a chair of the Mental Health Programme Board. I'm a little worried that we're not joining up the two agendas. Chris actually comes along and does a great job of presenting on the suicide prevention work that is a work stream, interestingly, of the Mental Health Programme Board. But we don't as yet have a prevention upstream element to that. And I think, and perhaps it's an action for me to take away, I think we're perhaps missing a trick in that regard, because we are at the moment seemingly having secondary or perceived secondary care conversations over here and other preventative primary care conversations over here, and there's a risk that never the twain shall meet. So whatever it is, I just think we need to do something to better join up the agendas. I hope that makes sense.
Yes, it does. I mean, certainly from, if I just come back, so Pete, so just to reassure, I'm recently taking on this area of work, so this is one of the first times where I'll have had a chance to meet some of you. So the work I'll be doing is absolutely making those connections in with health, and I think so it's, this board has happened sort of prior to any of those other engagements, so apologies for that. So absolutely agree. Again, some of the discussion we did have, I've taken over from a colleague who was working on it, was trying to make sure we didn't kind of clash over things like the engagement, so we weren't going out to the public engaging twice about something that sounded similar. So absolutely welcome that, Peter, and maybe that would be, you would be a good person for me to start with. If yeah, brilliant, thank you. I'll get in touch.
Thank you both. Alison?
Hi, thanks, Johnny. I'll just introduce myself because apologies, I was a few minutes late joining. So I'm Alison Bradley. I'm a GP in Warrington in North Staffs, and I'm the co-chair of the Health and Wellbeing Board, and also the clinical chair of North Staffs CCG. So I think first thing is really a comment. It's great to see this, and I think the thing that really sort of shouts out to me is that it needs to be owned by health and care. It needs to be a jointly produced and owned strategy, just so that it's truly aligned, and therefore that will support the coordination of the care and support and prevention that we provide to our citizens and patients. And I think just looking at your questions that are up on the screen there, I think for me, again, I would certainly confirm the support of engagement across, because everybody needs to know about it, everybody needs to own it. And also comment really on the second question. I think certainly the action plans need to be owned at the place level, really, because again, the how we deliver the strategy very much needs to be use the local assets and actually needs to address the needs of those sort of the needs at place. So it's just really comments, really. So thanks very much anyway for the presentation.
Thank you, Alison. That's Thanks. Really helpful. Thank you.
If it's any help, I'm tasked with strengthening and enhancing, I think it's a better word, the relationship between the County Council and the PCNs. And I see the district councils playing a part in that as well. So that feeds directly into this. I think the approach of place-based approach and a strength-based approach is exactly is exactly what we should be doing. Thank you. And clearly this has to feed into the JSNA, because and other pieces of work needs to feed into the JSNA, so we know exactly what we're dealing with and how we can manage it. Okay.
Yeah.
Anybody else want to chip in? Jan and Chris, thank you very much. Thank you both.
Thank you for your time. Thank you.
Simon, it's now you, I believe. Health Watch.
Right. So, good afternoon, everyone, again. It seems funny to be sitting here. It's 15 months since my last public meeting, so it feels a bit, ooh, instead of hiding behind that little screen at home, switching your camera on and off as you want and disappearing. So, we were asked to come and do a presentation to this board, and I thought rather than come and go over all the usual work that we do, because I would hope that most of you know what Health Watch is about, we'd actually ask the public what they thought about returning to normal. There's been a lot in the press, there's a lot in politics about it, and we just thought, well, we'll ask people in Staffordshire what they themselves feel. I mean, over the last 18 months, we've experienced anxiety, suffering, tragedies, restrictions on what we can do, whether it's employment, leisure, and it's been a real challenge to the health and social care systems, and I don't think anybody would have foreseen this could ever happen. But we've also seen great community spirit, marvelled at the ingenuity and resilience of frontline health and social care workers, and those that support the delivery behind the scenes, and not to mention the public health, local government, and the army of volunteers that have stepped up to the plate. During the 3 lockdowns in the intervening periods, Health Watch remained operational throughout. We ensured that our website was always up to date with the latest official government advice, Public Health England advice, and local area advice. We supported the public with their inquiries, signposting, intervening where we could, consulting, as well as on carrying, working with our strategic partners in a hopefully normal, collaborative and constructive critique manner. So when we were asked to come and provide this update, I thought I could tell you about all our forthcoming work. I just thought it's not advancing on the screen, is it? You know, that's the danger. I'm sitting looking at this laptop and you look up and you think, ooh, we're not going on there. So apologies to anybody who's following us virtually. You'll have been wondering what I was talking about and thinking, crikey's keeping it quite succinct. So we thought we'd actually go out and ask what people thought about things. We designed a quick survey, and I'm very conscious there are lots of surveys about at the moment, covering a plethora of different subjects and topics. So we set ourselves the challenge of just doing a 10-question quick survey. And we did it over a 2-week period. We promoted it in the usual way, social media, email, paper copies, some places, some focus groups, and thankful to all the partners, probably quite a lot in the room, whose organisations then also promoted it internally. So we actually got 523 responses, which I don't think was doing too bad, considering. Most of our responses came from residents in the 65 to 79 age group, followed by people in the 50 to 64. Fewest responses were from the 18 to 24. Other demographic information collected showed that 53% of people consider themselves to have a long-term condition, and 23% consider themselves to have a disability. 91% were from white British, English, Northern Irish, Scottish, Welsh, and then remaining 9% were from the other ethnic groups. Just a quick image there showing that we had quite a spread of responses, a few outlying areas, but this did go to workplace colleagues as well, so perhaps some do commute into Staffordshire. So, First, we asked respondents 3 questions. On a scale of 1 to 5, 1 being no threat and 5 a high level of threat, what level of threat do you think that the coronavirus pose to your area, to Staffordshire County as a whole, and then the United Kingdom as a whole? The general trend that can be seen is that people perceive their own area as the safest, followed by the county, and then the United Kingdom. Just 3% of people perceived their own area as a level 5 threat, followed by 5% of people perceiving Staffordshire County as a level 5 threat, while over 15% of respondents reported that the threat level to the UK was at the highest level. The trend can also be seen to threat level 4. 14% of respondents perceived their own area to be the level 4 threat, and 23% perceived Staffordshire to be level 4, and 30% perceived the United Kingdom to be level 4. We then delved deeper into analysing the respondents' perceived threat level by comparing that to the demographic information. To do this, we calculated an average threat level for each individual across the 3 areas. It's interesting that the youngest age group perceived coronavirus as the highest threat, despite probably being at the lowest risk from coronavirus. This age group reported the highest percentage of level 5s and the lowest percentage of level 1s. Surprisingly, and in contrast to this, the highest percentage of people with a level 1 response came from the oldest age group, 80 plus. So that's probably, seems bizarre when they could be at the highest risk. We proposed reasoning for this later on in the presentation through some further analysis. Of note is the cluster of people perceiving the threat posed to be at the middle ground at level 3. We then asked people how confident they were that the NHS would be able to treat them effectively if they contracted coronavirus. Overall, 81% of respondents were confident that the NHS would be able to effectively treat them, with a third point reporting to be very confident. And this graph compares confidence in the NHS to treat coronavirus by age group. The 18 to 24-year-olds, interestingly, showed the lowest confidence in the NHS. And 100% of respondents in the 80-plus age group were confident that the NHS would be able to effectively treat them. This is the same graph, but with perceived coronavirus threat added to it. This may help explain the high level of perceived threat in the 18 to 24-year-olds that we discussed in the previous slide. If they aren't as confident the virus can be treated effectively, it would make sense that they perceive the virus as a higher threat. People who consider themselves to have a disability were less confident in the NHS to effectively treat them at 75% than those who didn't consider themselves to have a disability at over 80%. Again, comparing this to the perceived threat of the virus, respondents who consider themselves to have a disability were also more likely to perceive the average coronavirus threat level as 5 at just over 11%, compared to just 1% of respondents who didn't consider themselves to have a disability. We asked people if they were taking part in the home testing initiative. 63% of respondents said they were currently partaking in this or they intended to do so. And when looking at this by age, over 90% of the 18 to 24-year-olds said they were currently taking part or intend to take part. In contrast, only 41% of over 80s said that they were currently taking part or intended to. There are perhaps a worrying figure to highlight. There seems to be a real lack of understanding of what home testing initiative is amongst some of the older Staffordshire residents. This perhaps highlights a requirement to do some more targeted comms. Nevertheless, this data also highlights the success of communications and the initiative itself within the younger age group. We wanted to give people who said that they weren't taking part in the home testing initiative the opportunity to share their views and tell us why. We conducted a thematic analysis of the answers given by the respondents. A lack of information was the most prominent theme. Respondents admitted they were not sure the home testing initiative was and had not heard of it before. As a sub-theme within this, respondents alluded to thinking that there was no need to take part if they'd been vaccinated or did not have symptoms. Other themes that arose during our thematic analysis were a lack of faith in the science behind the initiative being too intrusive, and feelings that the home testing is unnecessary. We then asked respondents, how confident are you in the ability of the Covid vaccination programme in Staffordshire to reduce transmission and the number of new coronavirus cases? 80% of people were either very confident or somewhat confident. This graph shows the percentage of people who reported they were either very confident or somewhat confident in the vaccination programme by age group. Younger age groups showed less confidence in the vaccination programme than the older age groups. 18 to 24s showed the highest level of unconfidence, that is those who responded very unconfident or somewhat unconfident in the vaccination programme compared to the other age groups. Again, we could link this back to the previous slides to offer an explanation as to why this age group perceived coronavirus as the highest threat. Of the 25 to 49 years group, 11.5% were neither confident nor unconfident, and the 50 to 64, 8%, and 65 to 79s, just under 7%. Although there were just over 6% of the 80 plus who were very unconfident. People who considered themselves to have a disability showed less confidence in the vaccination programme, just over 77%, compared to those that did not, at over 91%. Again, this could be linked with the discussion on the previous slides regarding those who consider themselves to have a disability, perceiving the coronavirus as a higher threat than those who did not consider themselves to have a disability. We then asked people if they were offered the jab, would you have it? Over 96% of people reported that they would already have had the COVID-19 vaccination. And when we analysed this further, the uptake didn't differ by age, ethnicity, disability, or long-term condition. Again, we wanted to give people who said that they would not have the vaccination or are undecided the opportunity to share their views and tell us why. We conducted thematic analysis on the answers given by respondents, and the main theme was concern for side effects and the safety of the vaccine. This perhaps highlights the spread of misinformation within Staffordshire, highlights yet still a need for more comms regarding the misinformation and about the vaccine's safety. Other themes related to a choice of vaccination. Some people were saying that they would have it if they could choose not to have the AstraZeneca, and concerns about the effectiveness of it. And some people were not sure the vaccine would work in reducing transmission in new cases. We then asked people how did they feel about restrictions being lifted. And this was on the lead up to, and the survey was still open after May the 17th when everything started to open back up a little bit more. Over 57% of the respondents said they felt somewhat anxious or cautious about the restrictions being lifted, with the least amount of respondents saying they felt very relaxed or unconcerned. Interestingly, the 18 to 24s were the most relaxed. It's interesting that they were the age group that reported the least confidence in both the ability of the NHS to treat coronavirus and the vaccination programme. But they do face the lowest risk equally. This age group was also most anxious or cautious, so this does show a big split within the respondents. Nobody in the 80 plus group reported feel very anxious or cautious about lifting the restrictions, despite possibly being most at risk. As mentioned in the previous slides, they also displayed the most confidence in the NHS to effectively treat coronavirus and the vaccination programme to reduce transmission. And those with long-term conditions were more anxious about the restrictions being lifted. Not surprising given the increased risk of hospitalisation from coronavirus for many long-term conditions, their above average perception of threat level and their lack of confidence in the NHS to treat those who contract coronavirus. We asked respondents since January 21, have you missed, delayed or avoided health or social care appointments due to fear of contracting coronavirus? Over 36% of respondents admitted to missing, delaying or avoiding at least one appointment. This graph shows the percentage of respondents in each group who reported missing at least one health or social care appointment since January 21 for fear of catching the virus. At the highest, 54% of people with a disability have missed at least one appointment, and this is followed by people with a long-term condition at just over 45%. Both of these groups are significantly above the survey average of 36%. Young people display similar to the average, 36%, with at least some of them admitting to missing at least one appointment. Older people came in lower than the survey average, with just 31% of over 80s missing one appointment. Impact of the pandemic on mental health. A large majority of respondents reported that the pandemic had some negative impact on their mental health. On the opposite end, fewer than 1% of respondents said that the pandemic has had a huge positive impact on their mental health. Young people reported the worst impact on their mental health, with over 27% of 18 to 24-year-olds reporting a huge negative impact. This was closely followed by people with a disability, with over 24% reporting a huge negative impact. Over 17% of people with a long-term condition reported a huge negative impact on their mental health. Older people, i.e. 80 plus, reported the least negative impact on their mental health, with only 12% of people in this age group reporting a huge negative impact, which is lower than the survey average. And that, you'll be glad to know, is the end of your death by statistics. Any questions?
Thank you. I'll take questions from the floor first, and then to those who are who've dialed in. Any questions? Any questions from those who've dialed in? I don't have so much as questions as comments. I think that was very thorough and really helpful. Thank you. The first thing to say is I think the testing piece teaches us quite a lot. And I wonder, Richard, if you can share this survey with the comms people to see if we can have a bit of a more nuanced approach to our communications about the whole testing piece. Because it does teach us stuff, doesn't it?
Yeah, we can certainly do that, Chair.
Yeah,
so
great. Thank you very much. The other thing as well is what's interesting in this is that you're highlighting the reverse to what we would have expected in terms of perceived risk, yes, and confidence in the system and all that sort of stuff. And there's two things for me that distinguish the one demographic from the other. The one is those who are economically active have in some ways had a much harder time than those who are pensioned off in terms of feeling insecure and all that sort of stuff. But the other thing is this. And I think that, social media has had can have a pretty pernicious and deleterious impact on people's lives as it is, albeit it's done great things for us as well. But it's the age group that's had the biggest, who most probably had suffered the most through disinformation and the like through social media, and I think that's something we need to consider as well.
Absolutely.
Okay. Anything else? Thank you, Simon.
Thank you.
Thank you. Better Care Fund, Roseanne. Are you going to get it, Richard?
I'm here, Johnny.
Oh, pardon me.
Sorry, I was just off camera. Afternoon, everybody. I'm just going to give you a brief update on the Better Care Fund. There was a paper, I believe, circulated to everybody. So I'm just going to give you a brief update on last year and then an update of where we've got early on this year. So firstly, with regards to last year, due to ongoing requirements to prioritise Kovid, etc., as we know, NHSE did not ask us for formal BCF plans to be submitted, and they advised us to continue with expenditure on existing schemes as in the previous year so that we could maintain capacity in community services. So that's indeed what we've done. We're still required to meet national conditions, which we've made sure that we've met. And in terms of the governance and audit, etc., we've completed a Section 75 agreement that's been drafted, sealed and signed off by the Council and the CCGs. And to sort of finish off last year's information, there is a requirement to submit an end-of-year report with info on how we spent the money, all of the schemes, and highlight any challenges and successes. So this has been completed, and I'll shortly be sending it to the chairs for your comments and approval also. So that's it in terms of finishing off last year's. Moving on to this year, I've put in the paper a bit of a summary of last year's funding compared to what we expect this year. So with the exception of the IBCF and the DFG figures which have been confirmed, all of the others are indicative currently. So I'll update these and share them once they've been published. In terms of formal planning for this year, there hasn't been any requirements published as yet. We all meet nationally and we meet with the regional leads, and they've advised last week, this still isn't out yet. So it should be coming out over the coming months. So in the absence of that, we have our Better Care Fund steering group, which meets bi-monthly. We're establishing subgroups to work on some of the schemes whilst we await a further update on the national policy framework and guidance. So given that we're now nearing the end of the first quarter, we don't expect there'll be any material changes to existing schemes, with just some adjustments to spending with inflation, etc. So given that this is going to likely move forward in the coming months, I would like to request that the board delegate approval of the plan once we know what we need to submit to the Health and Wellbeing Board Chair, so that this can then be produced, a Section 75 agreement drafted, and we can get this moving forward. Now, I've also included for reference details of the Disabled Facilities Grant funding. This will be passported to the district and the boroughs in June as we're required to do so. So that was the update in very brief summary in the absence of any kind of formal guidance this year. Does anybody have any comments or questions?
If I may, I'll just say something. I think that this is just effectively, I think saying it's a rollover is a bit too simplistic, but that's effectively what it is because of the COVID challenges. And as you say, taking into account inflation. The signing off of both the Health and Wellbeing Board chairs is, under normal circumstances, would make a lot of sense because of what it is. But given the fact that I'm now a cabinet support member rather than the cabinet member, I think it's fair for me to actually run with it and do the work with you in future years. But I think the formal signing off needs to be from the cabinet member.
Okay.
Now, that's going to be discussed to see whether that's the sensible approach. But I think, given the sums of money involved, it's only right and proper in the county council that it's the member with the decision-making powers who does this. So we'll just have to wait and see whether that's the case. But notwithstanding that, it was still right and proper that you brought it here now, and for the board to be happy with what we're doing for this year. But we just leave that single caveat out for the moment until we know the answer to it.
Sure. Okay. Thank you.
Does that make sense to you?
Yeah, that makes sense. Thank you.
Okay. Richard.
Chair, just to be clear, in the BCF guidance, the requirement is for the BCF plan to be approved by the Health and Wellbeing Board. So it is the Health and Wellbeing Board that is the entity that needs to approve it, rather than an officer or member of the council or an officer or member of the CCG. Historically, we've delegated it to the chairs just to try and make it easier. But just to be clear, the requirement is for the board, us, to sign that off.
Right. That wasn't clear to me because in cabinet, it very much appeared as if it was the two individuals. But if it's the board per se, then that's absolutely fine.
Yes, I think the options are either D as written, or we do it as a whole board by a sort of email circulation. That's possible as well. It's a bit more cumbersome, but it's not undoable.
I would prefer the latter under the circumstances. So can we arrange that after the meeting? Yep.
Yeah, certainly. Roseanne, you can arrange that, can't you?
Great, thank you.
Yes,
Thank you.
Okay. Yeah, no, that makes sense. Thanks, Richard.
Alison, hi.
Hi, that's fine. I was, I mean, it was really, I was just sort of agreeing with Richard because it is very much, it's for the Health and Wellbeing Board to sign off, so it was delegated to the two co-chairs. But are you asking, therefore, Johnny, or recommending that it's circulated to all members of the Health and Wellbeing Board?
Yes.
Yeah, okay, fine.
If it's a Health and Wellbeing Board decision, then if it's a Health and Wellbeing Board decision, then it needs to go to the then all the members need to be consulted for approval.
Yeah, okay, I support that, yeah.
Okay.
Okay, thank you.
Thank you. Any other questions about it? This year is so straightforward. I can't imagine there's much that people want to say. Okay, thank you. Roseanne, thanks very much. Thank you very much. Thank you. The Integrated Care Partnership. Is Tracy with us?
Yes. I am, Chair, thank you.
Hi.
Hi. Hi.
Just to say before we start this particular item, and please correct me if I'm wrong, but the ICPs as organisations don't appear in the white paper or are likely to be statutes, but it is an NHS England recommendation. Is that correct?
Chair, what I aim to do in this report is probably give that update, because you see there are two papers. I'm following on from the submission last time of the ICS development plan. There's a paper that I was going to ask Simon Whitehouse, ICS Director, to update on the developments of the ICS, but you'll also see a second paper on ICP development. But to correct, at the moment, in the proposals in the white paper, there's no statutory position for ICP, but I'm sure as we go through the two documents that you can ask your questions and be further updated. Is that okay, Chair?
It was the ICP I was referring to, not the ICS. Thank you for that. Simon, you want to come in, and would you just clarify exactly what Tracy said, because I couldn't hear it properly.
Okay, thank you, Chair, and thanks, Tracy. So, suggest we take these two items together, and Peter Axon will come in and talk about the ICP piece, and Alison will come in as well in the ICS and the ICP elements. So the papers as read and as written, and I'll come to your point, Chair, as well, in terms of the ICP and the statutory nature of the place part of the white paper. Just to recognise that the last meeting of the Health and Wellbeing Board received the full ICS development plan. That full ICS development plan's also been to Overview and Scrutiny Committee. Clearly sets out the approach over the coming months in terms of the establishment of what now will be a statutory organisation, as well as the underpinning elements of how providers will collaborate, the duty to collaborate between local authorities and the NHS, the duty to collaborate in terms of the wider partnership, the formation of a health and care partnership board, as well as an NHS ICS statutory element, and really sets out the four main duties in terms of improving outcomes for the population health and healthcare, tackling the inequalities and outcomes that exist across the system, enhancing productivity and value for money in terms of the use of the public pound, and helping the NHS play its role in supporting broader and social economic development. So recognising the role the NHS should be playing as a large employer in terms of how does it support that economic development and recovery as we come out of the COVID pandemic response. Since that last meeting, as I say, scrutiny's received the full development plan as well, and then we've had the Queen's speech, and the Queen's speech sets out really clearly that it's the government's intention to bring forward the Health and Care Bill in this session of Parliament to get royal assent by the end of the parliamentary term, which means that we'll be planning for the statutory footing from April 22, building on and using that ICS development plan to establish the ICPs, the place, the provider collaboration, etc., etc. Significant amount of work to do that underpins that. We've been talking about this now for a period of time, and it's important that we recognise that this isn't a new thing just because we're now going to get legislation, that we're actually building on the work that's been taking place over many months. The important aspect now is, I think the learning from Covid enables us and allows us to get to a point where we absolutely focus on the health inequalities, we focus on improving the outcomes, we recognise the access challenges in terms of some of the service response, and we've learnt an awful lot about the role that communities can play in supporting that response and supporting that engagement. So I think the whole integration conversation moves to a different place in terms of fast-forwarding some of those relationships and fast-forwarding some of those ways of working, which can only be positive for the residents of Staffordshire. In terms of your specific question, Chair, and then we'll get into the ICP piece as well. So you're absolutely correct. The white paper doesn't talk about a statutory body that will be an ICP. However, what it does talk about is place being the key area where the work of collaboration, the work of integration will be delivered. And so the expectation that will come through, and my understanding is it will be DHSC guidance, not NHS England guidance, which is an important differential in terms of the impact that will have, will be around how budgets are expected to be moved to an ICP and move through to a place level across the DHSC, not just from an NHS perspective. However, we need to wait until the bill comes out, it's gone through royal assent, and we've got the guidance that sees that playing through. And until we've got that, and until it's gone through the challenge in the House, etc., then there's an awful lot of work and water still to go under that bridge before we get to that end point. I think there's a risk that ends up becoming a distraction from the really important work that needs to happen in terms of the health inequalities, the health outcomes and the integration agenda, part of which, we've just heard in terms of the mental health piece, we've heard in terms of the obesity piece. So the Staffordshire and Stoke-on-Trent ICS has now been formally designated as an integrated care system. We've got the correspondence that confirms that, so the development plan's been agreed and been signed off nationally and has that in place. The other important point is we've talked previously around, and then I'll hand over to Peter, we've talked previously around a potential CCG merger in year, and indeed the GP memberships for the 6 CCGs have voted for that merger. Through conversations and through discussions, what's clear now, given the statutory nature of an integrated care system, that all our efforts and focus now is very much on establishing the ICS as a statutory body. So we will not be pursuing a CCG merger in year, because that effort and focus needs to be on how to establish the integrated care system by April of next year, and that will be all-consuming in terms of the work and the expectation of what will need to be put in place around managing staff transfers, managing the recruitment and everything that goes around that process. So the work around the CCG merger will be focused towards supporting and driving the ICS establishment over the coming months. But I'll hand over to Peter, who will take us through the ICP aspects, and then would rather use the time getting into the conversation and discussion, Chair.
Okay. Thank you,
Peter.
Thank you, Simon.
Welcome.
Yeah, if I may, Chair. So, you have in front of you a couple of documents, ICP documents. So the first one is essentially a plan on a page that tries to describe the objectives of an ICP in a single place on a page. The second document is the sort of the pinnacle of our governance arrangements in relation to ICPs, and we term it our visioning document, which is quite a lengthy document. But if I kind of try and describe the two together in as fewer words as possible. So what are the objectives of ICPs, which within that national guidance are described as places? So just to clarify that point, ICPs and places are one and the same. So the objectives are to firstly reduce inequalities, and we've heard the conversation about reduction of inequalities on a number of occasions already today. The second point is to ensure that we operate in the most effective and efficient manner possible, and we have significant challenges financially in the system, whether that be social care or the NHS, and I don't think they'll go away anytime soon. So that efficiency agenda is equally important. And also about finally addressing demand pressures. So that's very much about upstream working, so ensuring that we are addressing the wider determinants of health, those issues that ultimately cause ill health. And in that regard, putting more emphasis on prevention as opposed to treatment, whilst at the same time recognising, of course, that it's hugely important that treatment is done in the most efficient and effective manner. So at its heart, those are the three key objectives of our ICPs. And again, three key points, I suppose, around how we'll achieve that. So firstly, it's fundamentally about tapping into local voices and understanding local need. And you can only do that with boots on the ground, talking to local communities. The second point is around ensuring that we mobilise resources at a local level. So, of course, between us as statutory organisations, we have vast resources available to us, albeit they are under significant pressure. But there are also vast resources in the third sector, a voluntary sector, and, of course, with our volunteers, who we have many thousands across the county at the moment, but I'm sure there's a whole host of more opportunities in that regard. So there are a variety of resources that we both have at our fingertips now, but we also need to tap into. And then the third one is around data and intelligence. So ensuring that we have robust information to make high quality decisions at a local level for our local populations. So those are the three fundamental elements of how we'll achieve it. Of course, some of the infrastructure in relation to that. So the core engine room behind population health management will need to be managed at a system level. That's just common sense. The application of that information, though, logically sits at a local level. Just two other points, if I may. So firstly, beyond the visioning document, we also are creating what we call partnering documents that bring together, that bind together the various stakeholders within each of our ICPs to create more of a formal relationship across those ICPs, which in some sort of traditional circles you'd call an MOU, I suppose. But I think it goes beyond that because it's more cultural and is about partnership working as opposed to simply a set of technical points within a memorandum. And beyond that, we are creating what we term delivery plans. So these are three individual plans that address those fundamental objectives that I described a moment ago. So understanding what savings requirements and efficiency requirements there are, addressing inequalities, and ensuring that we move upstream as best we can to understand wider determinant requirements and ensure that we fundamentally move beyond treatment services alone. The final point I mention is that we've already undertaken quite a lot of OD work within each of the three ICPs. So we have vision, value and philosophy statements for each of our ICPs that have been developed with all of the partners. And again, for me, that goes to the fundamental point around culture. This is working in a different way. This is moving away from competition to collaborative working to ensure that we all aim for the same vision and for the same goals. I think I'll probably leave it there if that's okay, Chair, and perhaps move to any questions.
Thank you. Thank you, Peter. I'll take questions from from those who have dialed in before I take questions from the floor, or statements from those who have dialed in. Anybody who's dialed in wants to say anything? Thank you. I'll take questions from or statements from the floor about this piece. Who wants to speak? Richard.
Thanks, Chair. So first of all, a reflection on the integrated care systems. So the white paper that was published in February signals the government's intent to publish a bill. We expect that to be probably before the summer. That will create two things. One is called an ICS NHS body, which will replace the CCGs and be responsible for the NHS locally. The other will be something called an ICS Health and Care Partnership Board. The statutory basis of that is not clear in the white paper. Its function, however, is to produce a plan to address the health, public health and social care needs of the population. That is a plan to which partners will have to give due regard but is non-binding. It is also a function that sounds remarkably similar to the function of this committee, actually, and we probably need a bit of reflection as that body develops, because we could quite easily bump up against one another and end up doing effectively the same job. I'm not sure we can address that today, but probably one for future sessions. On the ICPs, so I think from the County Council, we look forward to even closer working with the NHS as an opportunity as these ICS arrangements develop. I think we probably need to understand a bit more about these ICPs before we can offer wholehearted endorsement. They do suffer a bit from being acute trust footprint based rather than truly place based. So they are north, southwest and southeast. They're not really on a geography that the general public really recognises, and they don't really correspond to how the local authorities organise our business. So we will find a challenge in things like improving health and addressing health inequalities at ICP level as well as at county level and as well as at individual district and borough level. It just provides a third geography for us, which is a bit of a complexity. And secondly, the document purports to show something called local authority provision falling under the auspice of the ICP. I'm not sure I'm clear what it means. I'm not sure we've got any immediate plans to cede command and control of our operations, either children's, adults or anything else, to the ICP. So we probably need a bit of further discussion about how we envisage that working out. And then in terms of governance, so I think the COVID pandemic has shown the best of collaboration in the public sector, and that's been characterised by being pretty fleet of foot. So people getting on with things, bilateral conversations, phone conversations, small tactical groups working to get things done quickly. So I'm not sure we're quite persuaded about the need for partnership agreements and chairs and boards and vice chairs and all of that sort of thing. I think there's a risk that it might constrain and slow up what we want to do rather than to facilitate. So again, probably something else that we need to discuss a bit further and understand exactly how that's going to work. Thank you.
So I'm sure Peter will, I'll let Peter respond to the ICP points, and Alison may want to come in on a couple of elements as well. I think Richard repeated a number of things I said in terms of what the white paper will say and what the white paper says and what that looks like. I think his point around the Health and Wellbeing Board and the potential confusion, stroke overlap, stroke duplication is a point well made. And I think there is value in, not in a formal meeting, but some form of design conversation, workshop conversation, starting to work through what that looks like and how we make the best of the resource that we've got for best impact for the residents of Staffordshire. I don't think anybody's got any interest in adding bureaucracy or adding duplication, but we need to make sure it works. I guess the headline bit in some of the ICP bit that I'm sure Peter will come on to is that the footprint actually fits around districts and borough councils. And so we get really closely into recognising place as being people looking at their neighbourhood and looking at where they are focused in terms of where do they recognise services from, rather than a big footprint and taking this back up to a Staffordshire level. But I think there's plenty of room for conversation and discussion in terms of what does that look like. And as I said in my introduction, I think the The role of legislation set out as clear in terms of driving that duty to collaborate. I guess what that means and how far we want to go will be how ambitious do we want to be for the residents of Staffordshire in terms of their health and well-being.
Before I hand over to Peter, I would just like to make one comment, if I may. The beauty of this structure is that up until now in Staffordshire, there's been 6 different strategies to look after people who've got very similar problems. I mean, if you're in your 60s, you live alone, you've got multiple long-term conditions, and you're financially challenged, your problems are the same whether you live in Leek or in Kinver. And what this does, it gives one strategy for the county and the city, which is helpful, and devolves the tactical approach to that strategy further down the food chain, if you like. That makes a lot of sense to me. What I think I see is the setup of the ICPs adopting a strategy, the approach that it has as an ICP is as if it were going to be a strategic organisation rather than a tactical one. And it seems to be top heavy in terms of bureaucracy and stuff. And one of the things I noticed, which I thought was, if we're going to do this properly, we need full and thorough clinical engagement. And clinical engagement always comes at a price. When you go to a meeting on behalf of the system as a partner in practice, the other partners are saying, well, whilst you're doing that, you're not seeing the punters with us, pal. Where are you? So I asked the question, why do we need a clinical senate type arrangement at ICP level when the strategy's already been made through the ICS at the clinical senate level there? It's issues like that just make me wonder about whether we're just trying to replicate ourselves.
So Peter probably wants to come in on this to start with, Chair, and then I'll follow up on a couple of those points. With
okay.
Yep.
Okay. Thank you, Chair. So it is about delivery. So ultimately, the objective of the ICPs is about converting the strategy, the outcome objectives at ICS level to achieving delivery on the ground. So and fundamentally, that's about boots on the ground. That's about enabling us to create capacity to deliver change on the ground. So an example of how that's to an extent already been done, the CCGs that are now not quite technically one, but operate as one, have gone through a consultation with all of their staff. And they've allocated out, I don't know the precise numbers, but I'll estimate about 70 to 80% of those circa 300 staff down to those places to effectively give resource to those ICPs to deliver that transformation agenda on the ground. And that's one example of really the new world operating. So moving away from competition, because a lot of those people that we're referring to historically would have been, knocking down UHNM's door or knocking down Combined's door and going through very detailed contracts to determine whether we've dotted every I and crossed every T. Now, that's changed. We're now in a place of utilising that capacity and resource to ensure that change happens for the better on the ground. And that's the kind of thing that we need more of to enable us to deliver those change programmes day in, day out at a local level. So I don't necessarily, Chair, see it as additional bureaucracy and resource. I see it as a new world, a new optimistic world that has got trust in it fundamentally, and it enables us to use our existing resources in a different way to deliver change on the ground, utilising big data, system level, really clever intelligence, really clever stuff, but fundamentally enabling it on the ground. Yes, we will need a little bit of governance and a little bit of oversight at place level, because we'll need to do some coordination of that work. But that's not going to create another layer in the sandwich, another large layer in the sandwich. That's simply ensuring that an appropriate conduit is in place from place level through to the likes of the Health and Wellbeing Board. And going to Richard's point, if I may, a moment ago, I agree that we need to get right the relationship between the two Health and Wellbeing Boards in Staffordshire and the places, whether that be one place, two place, three place, four places. That challenge exists. Now, my request is give that challenge to me, give that challenge to the ICPs to come up with a solution that's fundamentally effective, that works, that's got line of sight directly from the Health and Wellbeing Board down to the ICPs, and you, as chair, can eyeball one person from the ICPs to say, how is it going in Staffordshire County Council, irrespective of whether it's 1, 2, 3 or more ICPs that fit that footprint. Give us that challenge and we will co-design the solution, the most effective solution with you. Thank you.
Thank you. Before I turn to Simon, if I may, and thank you for that, Peter. Thank you for the challenge. Alison, do you want to say anything, or are you happy for me to move on?
Yeah, I just briefly, just a couple of things really. I think the first thing is, you know, I think we're all trying to work through, aren't we, that relationship between the Health and Wellbeing Boards and, because obviously we've got the two in Staffordshire and Stoke-on-Trent within the ICS footprint, and the ICS sort of partnership board and the ICS. And I think, you know, the guidance will be helpful, but I think we need to work through as a system, and Health and Wellbeing Boards and the system, how that's going to work best for Staffordshire and Stoke-on-Trent and our ICS. So I think, yes, we do need to have, but certainly need to have further conversations around that. I think just going back to your comment, Johnny, around the the clinical senate, actually it's health and care senate, and actually on an ICP footprint again we've got health and care assemblies, and really the role of those is to ensure that there is that sort of clinical oversight and clinical leadership in all the sort of transformation that's going to take place. So it will be the responsibility, each organisation across the whole of health and care will have representatives on those that Senate and Assembly to really provide that clinical oversight. So I think that's really key to this working. So rather than again, that will be part of the sort of governance, but will be not. Will be relatively light touch in terms of sort of time requirement. But again, it's delegating that responsibility to key individuals and key leaders.
So, thank you, Alison.
So very aware of time, Chair, and not wanting to take us in. Oh, sorry. Apologies. So aware of time, Chair. So a couple of bits just for clarification. I recognise some of the points made earlier. We'll need the royal assent of the bill, and whatever the health and care bill will say, that will be the legislation. The white paper does make it really clear, though, that it will be a statutory ICS NHS body and a separate statutory ICS health and care partnership. So it does talk about putting that in statute, not being autonomous or independent. I think the place agenda is a really important debate, and we need the time to get into that properly with districts and borough colleagues. We've looked at the way the police structure themselves, fire and rescue structure themselves in terms of having that place focus, but then a county-wide leadership approach, and we're trying to model some of the learning from that through into how do we make this work. But the engine room of delivery has to be on that place footprint, and that has to be focused on delivering the change, not saying we're coming up with a whole of different set of strategies that's going to be set at a system level, and then it's how do we get into implementation. Basically, that's as simple as it gets.
I agree that the place-based approach Some people have a difficulty with the definition of a place-based. So it's a local approach. It's as local as we can make it, because that's where people live. I think that is absolutely the right approach to take. As you can see, as the colleagues here have some reservation about our involvement in an ICP and what that means to us as an organization. And I think we need to get into the detail of that. And I think that the best approach to take is for us to take this out, a separate conversation out of here, and then come back with a more fully understood proposal that both parties can sign up to.
And just to clarify, Chair, that's the County Council, not the Health and Wellbeing Board. You're saying there as the County Council.
County Council.
Okay, thank you.
The Cabinet Member for Healthcare and Wellbeing would certainly want to be there. Dr. Harling would want to be there, and I would want to be there. And I expect Mark Sutton would want to be there as well, who's responsible for children, and Helen. Sorry, I'm giving you work to do, Mark. And then we can have a thorough debate about what this means for us, and what is best for our places in our communities. I have to say, I had an excellent meeting this morning with David Atherton about what they're doing with the PCN in East Staffs, and it's that local approach that really will help deliver the strategy that the ICS comes up with. I fully accept that, but we've got to get this right. Tim.
Thank you, Chair. I'm by nature an optimist. I've sat through a lot of NHS change, PCTs and PCGs and so forth, where I've sat in the meetings and they've been about moving resources and effort and focus away from secondary care and towards primary care and prevention and so forth, and I think that's right. I don't think it's produced as yet a radical change which has changed people's experience of health or brought about the sort of transformation and improvement that we've all been looking for. But I'm a believer, and I want to get involved in this and try to influence it to make sure that it can perhaps achieve that change. I welcome the move away from competition. I think a huge amount of resources were wasted in the past in competition at different levels. My concern, I guess, is that my observation over that period of time is that the pressure in the system and the pressure on the system, and in particular the resources available to secondary care just to meet the need that was there today, has always mitigated against the sort of change that the words on here describe. And my concern is that, you know, immediately post-COVID world, those pressures are going to be even greater and are going to be added to by the great pressures that are on primary care in terms of people accessing the service at all. I think the place agenda does have some real possibilities in terms of doing it, but it means a very real partnership in a way that we haven't experienced before between all of the different partners. That includes voluntary and community sector, district councils, as well as the county council, and indeed the population, to make those changes, particularly in those areas where we see very much ingrained inequalities in health. And I think we all have a responsibility to put a real focus on that. And I guess I'm looking for very clear signs about what will be different. The words on the page are great, but there's clearly quite a lot more work to be done. And I'm not being critical about it. I'm just saying, let's get involved in that level of work. And I understand, Chair, your wish to have a discussion as a county council around those issues, but I think my colleagues in districts and boroughs would welcome that discussion as well, either at the same time or a separate discussion, because I think we've got a lot to contribute to that, and this is probably the most important thing that we're going to be engaged in as a board. Thank you, Chair.
Thank you. I'm sure Simon would as well welcome district and boroughs being heavily involved in this process, so we get it right for everybody. Simon.
Thank you. Just a very quick one. I think just in all these plans and all these machinations of bringing everything together, let's not forget what it's being done for, which is the public, and to make sure that public voice is very much rooted in what they want to need, and not just always based on a computer algorithm that says this is where you need to do this and that. People are strange beasts, and they will defy what you plan or think is best, and they will vote with their feet and upset the system. So I think it's really important. And I know I've said this at other meetings, and I know Simon has given commitment to it, but I think it's right just to reinforce it here from Health Watch's point of view. The public need to be heavily involved.
I agree with you entirely. What people want is for us to deliver. They don't care whether it's an ICP, ICS, or anything else. They just want us to deliver for them. Absolutely right. So we'll arrange that meeting. Great. Thank you, Simon. John.
It was only on that. We do have slots in the diary around Health and Wellbeing Board workshops, so we could use one of those if you want to. It's just a suggestion. It doesn't have to be taken up.
Can I think about that? Thank you. Leave? Forward plan?
We've covered quite a bit of it on this agenda.
We have.
So we'll come back to some of the agenda items we've talked about today. Obesity, strategy, DPH report, and there's a few other things in there, but it's in the forward plan which has been circulated, I think. We'll firm the agenda up as we get a bit closer to summer.
Okay, great, thank you. I believe that's the end of the meeting. Thank you all for your perseverance and your patience, and we're there. And thank you for those who have dialed in. Thank you. Bye-bye.
Bye.